Okay, thanks so much. What a great 3 presentations. I hope your mind is as buzzing as mine is about where to go with this, and actually to alert you that, or remind you that our World Cafe discussion groups this afternoon will be actually to get at your views on some of these issues, like the one about purpose, versus data first and what works. So we're slightly behind schedule. We started late, but that's okay. We'll be able to catch up in the morning, and you will get a break. But these were such rich conversations. We'll take 15 or 20 minutes for comments and questions of our panelists. And Alonso, are you still out there? We'll see if Alonso is out there. But anyway, maybe he's just muted, or maybe he's not. So the floor is open for comments and questions for Steve and Rajiv and perhaps Alonso when he. Yes, ma'am. And do we have a microphone? Yes, we do.
Can you hear me now?
Oh, yeah, there you are. Good. Okay, we're just starting.
Good.
Thanks.
Right.
We're just starting the question and answer session. So.
Okay, good.
And would you introduce yourself and who you are? Yeah.
My name is Veronica Shepard. Please excuse me. My body is fighting the weather, constant change here in the Bay Area. And my question is to Rajiv. I also work with the Department of Public Health in Population Health Division. So my question is, I really appreciate that you shared about holding people accountable. What does that look like with populations such as the African American community would have with the social determinants of health that we already have? And I guess I really want to know, how do you teach people to hold organizations accountable when they themselves don't understand what that looks like because of the issues they face just to survive every day?
Thank you. Rajiv? Is your microphone on? But maybe you need to.
I can't say I have much experience in teaching people anything. Based on my children are my teachers right now, but I'm just going to pick up the last point. I think being able to hold people accountable also is a function of power and privilege. And if people are struggling to meet basic needs, they're struggling to meet basic needs. They're not really going to pay attention to diet. They're going to pay less attention to diet and exercise and anything about that has value tomorrow, because they're struggling to meet what they need to today. So there's a bit of a, I mean, there's a dilemma there. And I think that for me and where I'm shifting my sort of focus is focusing on making the changes in society by any means necessary to have basic needs met. I think without a certain level of basic needs, it is very difficult for people to be engaged participants, whether it's in the medical system or the political system.
Okay, thank you. Next question.
This is Israel from the San Francisco Department of Health. In your economic scales that you're taking, have you taken into account gentrification? I'll give you a perfect example. We applied for a CDC grant, and our data person ran 200% below the poverty level and 25% high school dropout. So when we tracked it, about 5 neighborhoods. Did we improve those outcomes? No, we built a condo, $1 million condo smack in a neighborhood. So how do we take into account when we look at county health rankings, gentrification?
Who'd like to take that? Steve, did you?
Well, I can't speak directly to the gentrification, but I think Rajiv's picture of GDP provides a really nice example of the fact that we often think that we're measuring something that we're not. So if you look at GDP, you say, wow, this country is doing great. But it does not include the consequences of what economists would call the externalities, the climate change, the environmental health services that would go in, the ecosystem destruction, the displacement of people, and all of those kinds of things. So part of the problem, I think, that we have with some of our metrics is that we think they're measuring one thing, but they also make us blind to many of the other things that are really central. And that leads to some significant imbalances, whether they're equity issues or environmental issues, because they're not central. And that's why our metrics have got to be relevant to the issues that we care about.
So
Alonso, excuse me. Alonso, you may need to hit mute out there until we get a question for you specifically. We're getting some feedback, I think, is coming through that system. So,
Got it.
thank you.
in respect, so I'm not going to answer the displacement question specifically, but I think so. But it's a more general there's a more general problem too, is that most of our measure sets and the way we measure things is cross-sectional, and when we talk about indicators or in one particular time. So to understand an issue like gentrification, you would follow a cohort, you'd follow a group of people. It's a dynamic process, and so a cross-sectional way of looking at things doesn't measure the dynamic process. I think that one of the new things we were doing that is important is to measure spatial disparities, which you can do with cross-sectional data, but you can't measure things that are changing in time. So but it's a very valuable point is because health can improve with replacement of people in an area, how are we going to take the temporal dimension into account? And similar to how you're following sentinel communities, there is a need to follow potentially sentinel people in communities. And we have a lot of, but then we get into privacy issues. And so it's a challenge, but it's a challenge worth looking at.
Okay, thank you. Next question. Yes, ma'am. Get the microphone and introduce yourself.
Thanks to all the panelists for your comments and your presentations this morning. I'm Helen Woo from the UC Davis Institute for Population Health Improvement. The comment about how indicators don't equal progress really resonated with me. I worked very much on the measurement side and healthcare quality and public health for quite a long time, and it's very frustrating because we know this to be true, but at the same time we have to start by identifying that measure scorecard. So how do we get to that progress side? Measurement itself and holding people accountable often is not enough. And this is a very complex issue. We're working with all these different domains. So moving from indicators to progress on that, how do we get there?
Who'd like to take that? And Alonso, feel free to join in whenever you wish. But
I could. Can you hear me?
yes, we can. Good.
Yeah. Let me join in on that because it links back to the last question. Because we have two measures about housing that we came to as a window into some of the issues around income inequality. How does it manifest itself? And so, this linkage of measures to action. So we have the two measures are housing unaffordability, and we're currently measuring that at 50% or more of income being spent for housing, and the other one's residential segregation. And I guess it gets to the previous questioner's issue around why $1 million condo was built instead of some other kind of community development, or another way of saying that is, what are measures that can help you understand actions that can improve life conditions in the community without gentrification? So we use those measures to catalyze actions like our work with the San Francisco Federal Reserve and other federal reserves to bring developers in to develop approaches to mixed income housing to improve housing stock without gentrification. So I think the way we're kind of approaching it is that there is an action element implied in the measure where there's a path to action implied by how we discuss the measures and put the measure out there, so that the metric and the actions are synergistic.
Thank you. Anybody? Steve, you want to add?
Yeah.
Is your mic on?
I think so.
Okay.
So I think there's some other ways to think about this, because when we look at many of these outcome measures, they obviously are slow, but communities have got to then choose among them which are these areas that are priority, and then what are the activities they're going to do, and those become progressively more local. We talk also about collective action, and then having to hold each group mutually accountable. And they have to make those commitments to each other, whether they're businesses, community organizations, healthcare systems, schools. And once they have those kinds of commitments, then there needs to be a set of mutual accountabilities. And some of it can be more formal. But I think Rajiv is right. You want to have the local commitment to do things that matter locally, or things don't really happen. But you can drive these things down by helping them look at what's the real outcomes that they want to go, and then find the interventions that they're prepared to take on, and then holding themselves mutually accountable.
Just extending just a bit on what Alonso said, and I agree with what Steve said as well, but I think we don't design indicators in silos. Alonso mentioned design them with a paired action. To extend that to the idea of designing a system, right? Designing a sort of a system that has an action, a measure of its success, a feedback loop, a working system. And so indicators, by putting out an indicator alone without, the alternative is put out and propose a working system where the indicator is a fundamental instrumental part of that working system.
Okay, thank you. Another question for our panelists? Yes, Matt?
Hi, Matt Stifel from Kaiser Permanente. This is related about the latency of the measures. Steve, in your list of criteria for good measures, you didn't list latency. You talked about it a little bit later. So you've introduced a sort of much broader set of indicators than we historically use in healthcare, and much more focused geographically. But these measures still all suffer from being old. And for multi-sector partnerships doing the work, if they have to refer back to 2-year-old measures, it's a red bead problem. I mean, they're chasing something that's in the past. So, any thoughts about it's actually about measured collection, data collection, as opposed to referring to the common data sets.
Anybody want to take that one on?
There's a couple of things that you're saying. One is the latency between, I don't know, when you say latency, just explain latency between what and what?
Data and the
okay. Okay, so I think the age of the data sometimes is relevant, but if the thing you're measuring doesn't vary much, and when you're talking about environmental conditions, there may be quite a bit more stability. There might be a daily pattern to it. So the age may not matter. I think that what's important is to think about the latency between the action and the indicator.
Alonso, did you mention that one of your measure sets uses Twitter as a database? Did I hear you say that? Oops, we can't hear you. Oh, there you are. Okay.
Can you hear me now?
Yep.
Yeah. We have essentially the ratio of Twitter discourse around illness versus more preventive discourse as our kind of placeholder social media measure. We'll have a little bit more robust one in a little while, but it's trying to get, again, real time kind of hopefully changing sentiment data about well-being. Yeah.
Thank you. Anybody else want to comment on the latency question? No.
Well, I think Alonso's making an important point that there's getting to be a huge amount of data out there, big data, and we haven't really figured out good ways to tap into that to do some of this. But the other is, if we're looking mostly at outcomes, they don't change very much, very fast. So you've got to get down to the things that are related much closer to the processes and actions that you're trying to change. And that needs to be done probably locally, because oftentimes those data don't really exist. And then we have the general problem that our data systems are really slow, not local, and we don't invest adequately.
You know, as somebody who's used mortality a lot in research and policy, definitely suffers from that problem. However, outcomes like low birth weight which are outcomes really, are much more proximal and can be more related directly to policy. So we can think about the choice of outcome measures as well. You had a question, I believe?
Hi, my name's Kelly Hunt. I'm working on an evaluation with New York State Health Foundation that's at the community level. And I think your question brings up for me the real importance of teaching that capacity at the community level for the people doing the work on the ground to collect their own data. I think Twitter can actually be used for youth populations to collect information. And I think there's a lot of ways that we can build that capacity up. It's something that we are doing in New York. And to get that real-time information and to keep people active and seeing change at the ground level, we have to help everybody to collect that information themselves.
Thank you for that comment. Question over here.
Hi, I'm Abigail. Can you hear me on the mic? Abigail Crock from Contra Costa County here in the Bay Area. And I have a question about thinking about the collinearity of all of these indicators, that the primary driver that we're talking about of poor health outcomes is race, particularly African Americans, and poverty, and that we're overwhelming ourselves with indicators that are all kind of going around that same point and overwhelming these communities with stacks and stacks of negative indicators that can be as disparaging as it can be a call to action.
Anybody want to speak to that? It is
I
interesting.
will.
Okay, good.
In our measure set, because we were really cognizant of that. And so if you have a chance to look at those 41, I mean, it is a mixture of indicators that don't, again, your point is so well taken. In the history of public way we've dealt with measures in communities, we've spent generations just showing people disparity data, deficit data, and that is not going to get you where you need to go. So part of what at least we're trying to do in our measure set is a much more asset-oriented approach. And then also measures that we think that can be moved through collective action. And then there is, because there is this inevitable and undeniable impact of inequity on all of these outcomes, there will be necessary collinearity because you kind of need to triangulate around the many different mechanisms that through which those disparities are addressed. And kind of an equivalent way.
The question is a really important one. I take that point. I must observe, though, that 20 years ago in a conversation like this, it would have all been tobacco rates and infant mortality and nothing else. So if we have too many social indicators that we're paying attention to, that's something we probably need to deal with, but it certainly is progress in our field. We have time for 2 more questions. You've been waiting patiently.
I'm Meg Aaron Calvert from the Center for Healthcare Economics and Policy in DC. I have a follow-up question to this idea of trying to move forward toward targets. We've been working with some communities who have the baseline data, the profiles, but are not satisfied that national or even state averages, as was talked about, are good goals or aspirational targets for them for changes in some of these key areas, both process as well as outcomes measures. Do you have some ideas or suggestions for best practices to help define aspirational specific targets for forward movement, for cross-checking how you're doing?
That's a great question. Who's going to take that one on?
I can speak to it a little bit, because I think we've had problems with that. If you look at the healthy people objectives, for instance, they are simply a percentage reduction that's pretty constant, and they're national, and they're not resonant. I do think it's helpful to have these local data that are from relevant comparison areas that you can then use as a standard. In the old days, we used to look at things like preventive screenings and say, well, what was the rate in the best state? That could be that could at least stand you as a benchmark, or in a state that's comparable socioeconomically, or a county. And there are data sets that allow you to do that. I don't think there's a magic number by any stretch, but there are things that you can do to say that, gee, that's a reasonable benchmark. I'll point out, because George and I think Martha will laugh, is when we did the public health strategies report, we sort of said, what's the benchmark for health and cost for the nation? And we said, by dang, I think if I'll have this right, by 2020, we want to be average compared to the other developed nations of the world and have average healthcare costs. And that was really aspirational because unlikely that we were going to get there. But it was sort of saying it sends the right message about what our problem was.
I think you're on the right track. There's nothing magical about it. I think I think the local group should be setting a local target, and that local target is based on what they want, what they believe is their ethics, what they believe is right, and what they believe can be done in the time in the time that they are measuring.
Okay, we have one more question.
Hi, I'm Susan Burden. I'm with the Beach Cities Health District in Southern California and the Blue Zones Project, and also working with Gallup Healthways polls. And we've been in that process for about 5 years. But what I was really struck with, because we pay for what we measure in the work that we do with the Gallup Healthways poll, and we like it because the community understands their measures. The community understands financial struggle. The community understands these things. But when you talked about measurement with purpose, that really inspires me because I think it could help. There's so much money wasted when at the local level you need that. All of us who are at the local level here, we need meaningful measures, and it's not getting there. Is there any platform academically or someplace that looks at, that kind of concept, measuring with purpose, as opposed to not? Or is that just a good idea you have?
I haven't.
It's definitely a good idea he has, but anybody want to chime in on that?
Well, I mean, that's basically what surveillance is about, is you do those things because you want to achieve a certain end. So these are not new, and we've had the data for decision making. We've had it under different names. We have a new name up here, data for action, and it really is
what I'm
about
saying,
these
if I
things.
might challenge that just a little bit respectfully, is like in our setting, like in Los Angeles, the county data. We have a population of 123,000. Alonso will tell you, county data doesn't help us at all in Los Angeles. Because of the way it's bunched in different sectors.
Sure.
So the things that are getting collected nationally, when you get to smaller communities and you're looking for those numbers, they aren't there in the way you need them.
That's for sure.
If they aren't there in the way you need them, then what value are they to local communities where the work is getting done?
I think that the challenge that we're facing is that it's the disconnect between being the doer of the action and, so we're proposing indicators for somebody else to do, right? And to somebody else to fix. And that's why this is different. When we're talking about like healthcare and a hospital, we don't come up with we come up with useful measures because we give this drug or this test or do this thing differently. We're in control of we're in control of the system. So it means that we have to do things in partnerships, just like we need to. So who is the engine, right? Who has the controls? All those people need to be part of the in which the indicator is operating, and we need to, maybe we're more of a convener. And I definitely hear in what Alonso was saying that idea has been brought forward in their selection process.
So
let me jump in because I really want to be clear that when we lay out these measures, we call them national because we can get national estimates for them, but they are catalysts for thinking about what is most meaningful at any other level, community, neighborhood, block level, of a related problem that you'd like to work on. So it is a starting point. To use a jazz analogy, it's just the initial tune. It's not what the different band members do along the way with key changes and variations. So I think in the development of metrics that matter, it's important to have frameworks that speak to the urgencies of problems we collectively want to solve, but then very nuanced, locally generated ways that we find the right metric to do that. That's what we're going to be trying to do in the Sentinel communities part of this work. But I just want to be really clear that we propose this framework as a pathway to getting to a set of highly variable local measures that might be much more meaningful and actionable at those levels.
Thank you for that. And actually, that again sets up really what we want this day to be about. I mean, we actually in the planning committee, I think I said when we began 6 months ago, let's do population health metrics, and everybody says, well, boring. When we got to metrics that matter, you know, then it's in the spirit of this conversation. And I don't think the book is written on that, but hopefully this morning, and particularly our conversations this afternoon, will build on that. So let's thank our panelists again very much. You've been so patient, so you need a break. So we will take a 15-minute break. We'll reconvene at 10:30, and we'll pick up the agenda along the way. We're a little bit behind, but we have places that we can pick that up. So thank you very much for your attention.